Hello everybody. Well, today we are going to talk about structure and function of joint and muscles. My eyes are going to be a little bit to the side because I am going to observe the PowerPoint which I created for you guys, and I encourage you to look at the PowerPoint as I try to explain some of the concepts which might need some explanation, more or less, and I encourage you to take notes and then compare them with, of course, with your book. But that's pretty much enough of the introduction. So let's just start talking about the joints. So first and foremost, what are the joints and why do we have them? Well, the joint is the junction between the bones, two bones or more. Sometimes two, sometimes like in the case of a wrist, of course, or carpal bones, those bones, carpal bones, are gonna connect to more than two bones. So joints allowed the bones to move or rotate. Without those joints, of course, bones themselves cannot do much. So the articulation between those bones is very important, and that particular articulation between those bones we're gonna call joints. But joints are also very important in transferring or dissipating the forces. And what I mean by forces, either gravitational forces or external forces. The joints dissipate those forces through the bones. Okay, so let's go to the next slide. Actually, the very first slide, which says synovial, amphiarthrosis, and diarthrosis joints. So we have different divisions of joints. We talk about joints in different categories. This is yet another category of joints. This is more anatomical or structural division of the joints. Okay, so let's talk about Trusses joints first. Okay, Trusses joints are between bones those are held very tightly. Those joints will not allow for movement. If there is a movement, it's really minimum. But think about rather no movement. And the best example of that would be your skull. You know from anatomy that your skull consists of many parts or many bony components. However, you can't shift those bones. Those sutures are going to be called Trusses joint. The other one is called amphiarthrosis. Amphiarthrosis connect two bones, allowed for better articulation of those two bones via fibrocartilage or hyaline cartilage, depending of what joint are we talking about. You got even one or the other cartilage, but always that cartilage is present. So the best example I can give you of fibrocartilage would be intervertebral discs and pubic symphysis. Those two structures do feature the fibrocartilage, and we're gonna call therefore amphiarthrotic joint. How about hyaline cartilage? Well, if you touch your ears, they are very pliable, but they always come back to the original shape. That's gonna be hyaline cartilage. The same thing with the bridge of the nose. Boxers, they usually break the nose so many times that they either lacking this cartilage, and therefore the noses are very flat. So this is another example of amphiarthrosis joint. Those joints, we will talk about them in this course to a certain extent, but primarily we are going to focus on diarthrotic joints. Well, diarthrotic joints are fluid filled, and they therefore they are called synovial joints. So either or it's correct, diatrosis or diatrotic or diatrosis joint or synovial joints. We usually, well, not usually, we do have them in upper and lower extremities, and those joints allowed us to move. Since kinesiology is primarily about movement, of course we're going to target those joints in much greater details than the others. For our purposes in this course, the diatrodial or diatrosis joints are going to be more important, so to speak. Okay, let's go to the next slide. Every diatrosis joint has to have those 7 elements, and they do. However, of course, there are some diseases like osteoporosis and osteoarthritis, rheumatoid arthritis, among many others, which are going to destroy or negatively influence one or other of those 7 elements. So, as per name, synovial joint tells you that every joint has to have a synovial fluid. Think about that synovial fluid like the oil in the engine in your car. Without that, you would ruin the engine. The same thing with synovial fluid. If you don't have that fluid, you can, first and foremost, it's a lot of pain, causes a lot of pain, but also you would damage the joint very quickly. Articular cartilage is very important. Articular cartilage, by its name, articular, articulates the bones. So each articulating bone or each partner, bony partner of that joint is covered in a very thin layer of cartilage. Then we get synovial membrane. Well, where all those features are gonna be embedded? Well, they're gonna be encapsulated in synovial membrane. Synovial membrane is right under the articular capsule. It's like the inner lining of the articular capsule. Synovial membrane has a couple of very important features. First and foremost, they won't allow any other fluids or things which can harm the joint to pass through it. And that's going to be the outer layer. And the inner layer is responsible for actual production of synovial fluid. So synovial membrane, it's a kind of like an inner part of articular capsule itself. Then we got capsular ligament, which of course hold the whole articular capsule and all the features inside tight to the bones. And that's very important. Joints have blood supplies and nerve supplies. Where is blood, there is life. So this is a good thing, because if we damage the joint, there are chances that with proper treatment the joint will heal. Without blood, of course, this would be impossible. Sensory nerves are very important, because we can, for example, we can feel pain, and this is a good thing. Well, sometimes it is, sometimes it's not. But the pain, generally speaking, is if it's acute pain is usually good, when chronic pain is not. Chronic pain, think about chronic pain as acute pain going rogue. Acute pain is something is wrong, something happened, you have to pay attention to it. Could be potentially life-threatening. Chronic pain is different. Chronic pain is unnecessary. We don't need it, we don't want it. We spend billions of dollars a year to fight it, but it is a part of life, unfortunately. Okay, let's go to the next slide. In addition to those 7 elements I just mentioned, we have other structures in the joints. However, that 7 which I just mentioned are in every joint. Those additional ones are not in every joint. but some joints do have them, others don't. So I just want to mention two for our conversational sake, so you are aware. Well, first one is made from fibrocartilage, so like fibrocartilage pads. For example, they called menisci in the knee. Why they are there? Well, when we're gonna go to knees, we're gonna discuss the knees. We're gonna discuss this in much greater details. But for now, just heads up, is that the bones in the knee do not congruate perfectly. The connection is somehow rough. So in order to increase that congruity between the bones, the menisci are kind of helping the bones to get together and work as a team, so to speak. So they do increase the congruence of the bones in the knees. The other one which I want to mention is fat pads. Fat pads. Well, those fat pads are placed in the non-articulating places, meaning the bones don't necessarily come together, but there are other places within the joint which otherwise would be empty or just filled with some fluid. So in order to protect those bony structures, a lot of times we have those fat pads which we have in bigger joints. We have them, for example, in our elbows, in our shoulders, the big joints. we do have those fat pads. Okay, let's go to the next slide. Another set of or different way to divide joints, but this time we are strictly talking about synovial joint and how they work in our body and how we can divide them into the appropriate way they work in our body. So the way they work is gonna dictate how we call them and what they can do, therefore what human body can do. So the first one we're going to talk about is hinge joint, then pivot joint, ellipsoid joint, ball and socket, plane, saddle, and condyloid. Okay, so let's go to the next slide, which clearly shows you the hinge joint. So this is in the picture A, you can see just the hinge of the door, just to show you that the name hinge derived from that. And then you got an elbow, humerus and ulna. So this is a perfect example of hinge joint. What we can do with hinge joint? Well, hinge joint has only one plane. We can work only with one plane, therefore can do only one thing. Of course, in the elbow case, we can only flex and extend. Okay, let's go to the next one. Pivot joint. Pivot joint on the left hand side, the picture A, is like a doorknob. So you can clearly see that also can do only one thing. Either you can squeeze it right or left. So also have only one plane. So what are we looking here? It's a proximal radio-ulnar joint. Proximal radio-ulnar joint. That's what you can see on the picture B. Okay, so the head of radius rotates around the ulna. That's all it can do. Just turn around, just like the knob. The second example in our body would be atlantoaxial joint. Atlantoaxial joint. So that's the joint between your first two vertebrae. That's primarily what they can do as well. Rotate. That's how you rotate your head. So those are the example of pivot joint. All right, let's go to the next one. Ellipsoid joint. Okay, here the situation it's a little bit different. Now we can do two things with the joint. So we're gonna call it that the joint is two-plane joint. So what can we see on the picture? A is just showing you how those joints really work, but let's focus on picture B. Okay, so what can we see? This is articulation between radius and ulna. We're gonna take them together as a unit, not as one bone, rather as a unit. And the other unit also is the proximal row of the carpal bones. So one is very concave, the other one is convex. So it's elongated concave surface and elongated convex surface. What can we do? What our wrist can do? We talked about that already. So we can flex, we can extend, and either you can call it abduction, adduction, or radial ulnar deviation. You can use those names interchangeably. Okay, so that would be a good example in our body. Okay, let's go to the next one, ball and socket. Well, this is the most versatile joint in our body. Why? Because have 3 planes. So you can do abductions, adductions, flexions, extensions, and rotations. What would be the best example of it? Of course, our shoulder, and hip. Okay, so what else can we say about it? Well, one bone is of course concave, and one is convex, right? On this picture we can see the very prominent head of the femur and concave part of the pelvis. So this is perfect example of very deep connection, very good articulation between femur and pelvis. And clearly, just by looking at this picture, you can see that this joint was built for some mobility, but primarily for stability. It's very stable. Okay, let's go to the next one. Plane joint. Well, this is articulation which also allows two planes of motion. Okay, so it's clearly on the picture A is just showing you the book, what you can do with the book on the table. You can rotate or you can translate in any direction. Nevertheless, the directions doesn't mean that you can do more. It's just that you can change the directions. So it's still considered only two planes of motion, either back and forth, left or right, or rotate left or right. Which bones behave this way? Well, carpals, and you can see on the picture B, and you have the metacarpals shown, the 5th and 4th digit, and the hamate. So this is a perfect example of the movement you can do, well, where mostly in your knuckles, right? We're talking about your knuckles. Okay. Let's go to the next one. Okay, saddle joint. On the picture on the left hand side, A picture, you can see the saddle because it's easy to understand. I think it's easy to understand. You have two surfaces on the same bone. That's the trick over here. On the same bone, you have two surfaces. One is convex, the other one is concave. So as you look at the saddle from back to front, you have concave. And from side to side, you have convex surface. So depending how you look at that, it's this way, but at the same time, it's that way. Okay? Or actually like this and like that. I'm trying to find the camera with my hand, and it's sometimes not easy. Okay, so carpo-metacarpal joints of your thumb would be carpo-metacarpal joint of your thumb would be the perfect example of this plane. And what can you do with that? Two planes again. You can abduct. Adduct is one. If you go one side and you're coming back, that's only one. So it's abduction, adduction, but also extension and flexion. So the saddle joint allows us to move in two planes. Okay, so let's go to the next one, which is condyloid joint. Condyloid joint. It's similar to ball and socket, but is somehow different. How is different? When one is shallow, one bone is very, very shallow. So for example, and this picture B shows you our knee. So you can clearly see that the tibia is very shallow. Femur, however, have very prominent features. Those bones don't congruate easily. They don't really fit because of the flat surface of the tibia. So that's why we have menisci, the fibrocartilage, which is going to allow for the better congruency between those bones. Okay, how many degrees of freedom do we have? 2. We have 2. However, this is a little bit tricky joint because we can do either or. We can do either flexion and extension, which is 1, and abduction and adduction, which is the second one. And for that, the best example is metacarpophalangeal joints. Metacarpophalangeal joints. Okay, we can abduct, adduct, flex, and extend. But there is also joint which we commonly know as knee. What can we do with the knee? Well, knee can flex, knee can extend, but the knee also rotates. Now, we don't observe the rotation of the knee, but we're going to talk about it when we are actually talking about the knee. But we really don't see that rotation. It comes automatically. So as you extending your knee, there is a slight rotation, few degrees of rotation within the knee. So technically, the knee joint has 2 degrees of freedom and is a condyloid joint, and that's why it's presented on your PowerPoint. Okay, so this is it for the different types of synovial joints. Let's talk about something else. Joint forces. Forces occur in the joint secondary, and I'm just reading directly from your PowerPoint, so just please follow me with the PowerPoint, and I will try to explain things as we go. But I do want to read the PowerPoint because, after all, that's why I presented to you. Okay, so the forces occur in the joint secondary to primary forces of the muscle contracting, gravity, external resistance, or friction. So joint may be distracted or joint can be compressed. Okay, and we utilize those techniques as therapists. As a COTA, you probably had the opportunity to utilize those already. And certainly you will do it as an OTR because it's one of our techniques. We can either distract the joint. How can we distract the joint? Let me find the camera over here. So as a therapist, you ask your patient to relax and you pull the arm. So you are actually elongating the features over here. You are distracting that joint. Or you can weight lift, like I'm lifting now here the bottle with my shoes over here. I am contracting, so I'm compressing by weight bearing. Okay, so you can do either or. Okay, at a normal level of activity, a joint can resist the forces imposed on it. So if nothing is wrong, if we are healthy, we can do all our daily activities without problems. However, when we get in trouble, well, first and foremost, if you have some type of accidents, incidents, diseases, sicknesses, that's of course. And secondly, when you're trying to do more than you should, then your body is designed to do it. And again, coming back to my previous example from the gym, I've seen guys who are trying to do more perhaps than their body was designed to do, and they even lifting the weights incorrectly, because in the correct posture this weight will be just simply too heavy, but they do it anyway. So they changing the postures, they substituting, or they even, you can call it like cheating movement. So what does this do to their body later on in life? Damages, it's called micro damaging your joints, micro damaging your muscles, micro damaging your entire body, and later on in life they usually have developed chronic pains, chronic conditions, a lot of pain, a lot of discomfort. Our bodies are designed to do what we are designed to do. You can train yourself to do more, but you cannot go over it, because once you do that, then you are in trouble. Okay, let's go to the next slide. And I did mention that already. We have joint pathology, we have acute trauma, we got chronic trauma. So acute is of course a good thing, because it's a life-saving thing, right? You put your hand on the hot surface, you're gonna withdraw your hand instantly, and you're gonna feel the burning sensation. It's a good thing. If you didn't know, you could leave that hand to be burned. Ultimately, you can die from that. Chronic, however, is different. Is for being or overusing your body or body parts for many years, or micro traumas for one reason or the other. And chronic pain, it's not good. We don't like it. Causes a lot of pain, discomfort. It's something which potentially could be lasting months, years, or even some people suffer from chronic pain for the rest of their lives. Unfortunately, I have chronic pain. I have chronic pain in my lower back and my neck. So it's not fun. It's not fun. And I know for a fact that probably half of you suffers from chronic pains. And everybody knows this. It's not fun. So other diseases also cause, of course, the joint pathologies, and those are just two out of the never-ending list. But osteoarthritis and rheumatoid arthritis. So I do encourage you to read a little bit about both of them, or remind yourself about it, because I do know that you are familiar with those diseases, conditions, and that you learned that in your OTA school. But nevertheless, please refresh your memory at least a bit about those two conditions. All right, let's go to the next slide. Effect of aging, and you can see over here two pictures which are my really favorite pictures. You can see the old lady who is amazingly flexible. I think she had to be an athlete in her younger age. And the other one, you know what, once you're 100, what the heck, have a smoke. I love those pictures. Anyway, so effect of aging, of course, is huge. Can be modified. Are we doomed to heredity? Partially. Heredity plays huge role, but we can modify our lifestyle and we can fight heredity, and we can do pretty decent job with that. So we are not really doomed, or we can do better if we want to, of course. So by our lifestyle modifications, right? So nutrition, going to a doctor at least from time to time for good checkups, drinking water as opposed to soda, all of this good stuff. I don't need to tell you about it. You know this very, very well. And again, microtraumas can contribute to structural failures, and if you live to your 80s, 90s, or above, all of those people look differently. They are fragile, they are much smaller, because of those microtraumas and internal dehydration of structures. Of course, less water in the body, people are prone to adhesions, internal adhesions of the muscles and other structures inside the joints and ligaments and tendons, and that's why people do not move as swiftly, as gracefully, That is normal aging process. But again, we can fight it a little bit. Okay, the next slide is talking about functions of the muscular system. Generate tension that is transferred to the bone via tendons. So tendons are of course part of the muscles. This is not the working unit. The working unit is like the belly of the muscle, right? But tendon is not really working unit of the muscle. It's like a rubber band almost. It's behave, either relaxes, allows bones to go down or up, whatever you want to do, or whatever you're doing, but is a part, integral part of the muscle itself. So when tension is generated, a compression force is applied across the bones, therefore stability is enhanced. And to the contrary, let's go to the last point, depending on the line of pull and direction of movement, muscle can also pull segments apart. Stability reduced and movement occurs. Okay, so let's analyze this a little bit. You can have one or the other, but not both. You can have either stability or you can have mobility. Okay, so if you tense your body, you have stability. I can tense. Let me find the camera over here. Wrong way. This arm. Okay. I can get very tense, but then I can't move. No movement. Am I stable? Is this a packed position? Am I stable? Yes, I am. No movement. I have to relax. I have to have my joint in the loose packed position. I have to relax my muscles. Can I now move? Yes, I can. But the muscles cannot be contracted. They have to start working, and therefore the stability is less, right? So it's stability, no mobility, or minimum mobility, or great mobility, and then lousy stability. Okay, so let's go to the next slide. It also distributes loads and act as shock absorber. Protect the skeleton. Of course, the muscles are all over us and they covering the bones. So when you hit yourself accidentally, they act as shock absorbers. Support and protect organs and internal tissues, and have an effect on pressure inside the body cavities and on the body temperature. Well, this is actually very important concept for us as healthcare providers. Let's talk about this just a little bit. What do we mean by pressure and body temperature? Well, we all know, it's here in South Florida, of course, not because you're always hot, at least I am always hot, but when you are in colder climate, let's say New York or Milwaukee or whenever, right, up north, the temperature can really drop significantly, especially during the winter time. So what is the best way of keeping yourself warm except putting more clothing on? Well, movement. So muscles, working muscles, generate a lot of heat. So the body temperature could be regulated by the muscles themselves, right? You can keep yourself warmer by moving more vigorously. Also, the pressure. Heart, it's approximately the size of the fist. Really, it's not that big. So the heart pumps the blood somehow insufficiently for the sufficient blood supply, especially to the distal parts of our body, such as toes and fingers. We need movement. That is so important in healthcare for us as OTs, because we know that the best thing for our patient is to get them out of bed. Get them out of bed and make them move. That's gonna help them tremendously with the internal pressures of the fluids and the blood, which can then supply the distal, especially the distal parts of the body. Okay, all right. Let's skip to the other. This we don't really have to talk about it that much. The different muscles, you well familiar with that. In this course in kinesiology, we are going to talk strictly skeletal or striated muscles, which are muscles which we are going to use for movement. So let's go to the next slide. We already talked about it, so I'm not going to spend any time on that. Those are pennate and fusiform muscles. We talked about that last time. So let's talk about the structure of the muscle. Well, it's a fascinating structure of the muscle. So the entire muscle, as you can see on this picture A, the one above it, muscle belly, right? So this is the working part of the muscle, is enclosed in tough connective tissue, which we're gonna call epimysium. So this is a tough connective tissue encapsulating the entire muscle. But inside that epimysium, we can find a smaller unit of the muscle, right? Fasciculi. Those are one fasciculi. When you pull out one fasciculi, you can see it in the picture A. It's pulled out. This is one fasciculi. One fasciculi consists of many muscle fibers, individual muscle fibers. And this unit, as you can see, it's a unit. It's enclosed in its own tough connective tissue, which we're gonna call perimysium. And you can see those names on your PowerPoint as well. Okay, but inside we can find even smaller parts. Those are really proteins, and two proteins which you probably most likely remember from your anatomy and physiology class. It's called myofibrils. And those myofibrils are also enclosed in their own tough connective tissue, which we're gonna call endomysium. Okay, so we are taking one of those features out, and you can see in the picture B, the one below, we're gonna take those individual proteins out now. One is called actin, the other one is called myosin. And really, those are the working horses. Those are your units, those proteins, which actually interact with one another and making the muscle work. Okay? So actin and myosin is the working unit. Okay? Think about if you ever been on the cable cart in the mountains. Those cables are actually built in the same way or similar way. There is never one thick cable, simply because this one thick cable would be too brittle, would break under that enormous weight of the carts with people on it. So instead, and that idea was probably taken from our muscles, the same way Mr. Eiffel, when he was constructing or creating the Eiffel Tower, took the idea from our bones. This is exactly the structure of our bones. Inside, when you cut, let's say, the head of the femur, that's how the bone is constructed inside. And he took that idea and he built very solid structure, which is standing now for 200 years or so. So I do believe that the cables used in those cable cars are also taken from the idea was taken from our muscles, because the muscle is consists of so many different layers. On the end of the day, it makes them incredibly strong. Okay, so let's talk a little bit more about muscles. So 5 general characteristics of each muscle. So contractibility, irritability, relaxation, distensibility, and elasticity Those are the 5 general characteristics of each muscle which we can control with our mind. Contractibility, muscle contracts, then therefore produces tension between the bones, and we can pull. Now, this very important concept here to understand, that muscle cannot push. Muscles can only pull. So what are we doing when we're pushing something away from us? We're utilizing muscles which are actually pulling, but we are utilizing those muscles in such a way that we are apparently or obviously pushing something away. But the muscles are incapable, biologically speaking, are incapable of pushing. They can only pull. This is how the actin and myosin work. They can only pull or relax, pull or relax, but they are incapable of pushing, because otherwise, if you push the muscle, you destroy the muscle. All right, so this is a good thing to know. Then is irritability, ability to respond to stimuli and transmit impulses. So you're responding to your environment, either internal or external, such as pain or heat or cold. You can withdraw your hand very quickly, so you irritate the muscle, either externally or internally. Muscle have to have the ability to relax. If not, would be one way, one-time use. You can contract, and that's it, and you're stuck. So muscle must be able to relax. Distensibility can be lengthened or stretched by a force outside itself. All right, so if I'm a therapist, I can actually elongate this muscle, extra pull, right? Elongating that muscle. But what the normal healthy muscle needs to be able to do, needs to be elastic in order to recoil to its original shape. Otherwise, again, would be one-time deal. I stretch somebody out and that's it, right? We don't want that. Your license is gonna go bye-bye. So elasticity, muscle coming back to its original shape. Okay, let's go to another slide. Nervous system. Of course, we know that brain controls our voluntary movement, and we can choose. Therefore, because it's our brain, so we can choose between fine motor skill or gross motor skill. We can choose if we want to walk slowly or we want to run. So brain is the main computer controlling that. So provides control, coordination of contraction of muscles, fine control over speed, length, and tension. And of course, central nervous system consists of brain and spinal cord. Some of those decisions are taken away from brain and are conducted by spinal cord, because we can't afford to lose the precious time for the signal to get to the brain to actually analyze the data and send back the information what to do. We can't afford it. We can actually literally die. So instead, the spinal cord shorten that information travel, and the acute pain, such as a burning sensation, it goes to the brain, but you react before you feel pain. Why does this happen? Well, because your spinal cord picked up already signal that this is too hot. Too hot is very dangerous, and you are burning yourself. So before your brain actually registers the pain, your hand is already withdrawn. The withdrawn hand is due to almost instant reaction from the spinal cord. The reaction later, the feel of pain comes from the brain, but always couple seconds later. Okay, brain simply needs time to process that and give you a signal. How much pain? Is this a little bit pain, or you burn yourself a lot and therefore it's going to be a lot of pain? That decision is made by brain, but the withdrawal of the hand That decision is made by spinal cord. And then you have the peripheral nervous system. Of course, all of the peripheral nerves are coming either from the brain or the spinal cord. So they're further divided into motor nerves or sensory nerves. Of course, the motor nerves are the ones who are responsible for giving signal to move the muscle, and sensory nerves are the ones which are going to be responsible to feel cold, hot, pain, no pain, and soft touch, rough touch, you name it, the list is long. Okay, so let's go to the next slide. Okay, this is somehow complicated, so I would like to talk about it a little bit, and let's just start with that. Nerve muscle functional unit. We talk about the unit already. So primarily all motor neurons in skeletal muscles called alpha motor neurons, and we talk about it. So you know already that the muscle fiber, the nerve muscle functional unit consists of what? One alpha motor neuron, which comes directly from the spine, and then divides itself into smaller parts which actually connect to the individual muscle fibers. So one axon with those tentacles attached to the muscle fibers, it's called one unit. Okay, those units, now let's take this to another level, can vary in size. And this is a very important concept, because we have muscles which are responsible for stability, we got muscles which are responsible for fast movement, and we have plenty of muscles which are somewhere in between. Okay, so important thing to remember here is that every muscle has all types or all sizes of the muscle, nerve muscle functional units. However, depending of what are those muscles doing, they're gonna have more of one type, less of the other, and even less of the third one. So yes, there are three different sizes, and I couldn't find it really in the book, but probably somewhere there, but I would like to draw my own. So this is what I just drew by hand, and I'm going to explain it to you as we go. I will just try to keep it steady so you can see. So we can divide by slow, middle, and fast. So again, we are talking about the functional nerve muscle units. Okay, so over here you can see all the way over here amplitude, here duration. Okay, so as you can clearly see, this line over here is very low in amplitude but long in duration, right from here to here. The next cycle starts here and go all the way over here. So it's very low in amplitude. I'm losing. Very low in amplitude, but duration is great. They are slow. Okay, and again you can see it over here. Great duration, low speed. They are used for posture. Okay, so those muscles which are low in amplitude, long in duration, they are going to be the muscles which you use for endurance. Okay, they are not fast. So therefore, think about your posture. Think about standing for prolonged period of time, sitting in the chair and watching this video for prolonged period of time. Posture. Okay, now let's go to the third one. The third one, which I will try to show you right here. There we go. So as you can see, the amplitude is very high, but the duration it's not. They are high and short. Can you see that? So they're gonna be here. Low duration, but great speed. So those muscles reach in those nerve muscle functional units are going to, those muscles are going to be very fast. So we're going to use them for jumping, throwing, sprinting, you name it, movement, fast movement. But not all the muscles are built either for great duration or great speed. We have a lot of muscles in our body which needs to have a balance somewhere in between. So I'm going to show you this somewhere in between right here. Okay, so amplitude is moderate, duration is moderate, and they are somewhere between fast and slow. Okay, so I hope you enjoyed my Picasso style handwritten stuff over here, but I hope that everybody understands this concept. Okay, so in other words, small motor units are used for posture. The large motor units are used for movement and force. Okay, all right, let's go to the next slide. No, not yet. Fibers of each motor unit are dispersed throughout the muscle with fibers of other units. A number of units needs to fire to make a joint angle change. So let's talk about this just for a few seconds. It's not enough if only one motor unit fires. It's not going to do anything. Those are the muscles which are not working. Those are sometimes the CVA patients suffer from that. What I mean by that? Well, the information is going through the brain, but reaches the muscles in limited capacity. The brain is incapable of sending all the signals. So only some of the units fire up and the others do not. That doesn't work like this. We all seen CVA patients or other patients who suffer from let's say paralysis, right? So the motor units have to fire all or none. We either so to create a movement, many motor units related to that particular muscles have to fire up. Okay, let's go to the next one. All muscle fibers in a motor unit either contract or relax at the same time. One fiber cannot contract while others relax. So this is like a piggybacking on the backing on the other issue that I just mentioned. You cannot contract part of the muscle and leave the other part of the muscle to relax. It doesn't work this way. You have to contract the muscle, entire muscle, or you relax entire muscle. Okay. And I mentioned before when we were talking about different types, fusiform, for example, and you got the different types. So here I brought the picture which you can actually appreciate that we have more type of muscles than just pennate and fusiform. However, as you can see, there are, if you want really divide them into two major groups, it really fits well with either pennate or fusiform, with some exceptions, of course, of the circular muscles, which you got around the mouth or eyes and stuff like that. Okay, so you can take a look at that PowerPoint, look at the picture, and appreciate that we have different types of muscles in our body. Okay, let's go to the next slide. Muscle tone. Muscle tone, it's easy to detect, and this is a firmness. Muscle tone is a firmness of a muscle. So best way to do it is by touching the muscle, looking for the camera here, touching the muscle and feel the belly of the muscle if it's firm and spongy or is soft and saggy, right? But also postural tone. You don't have to touch anybody. You can just look at somebody and see the posture, and the posture by itself will tell you if the muscles are firm and strong or not. Because gravity is it's a force. It's an external force, and we cannot escape gravity. Gravity works always, 100% of the time. So you can just look at somebody and assess if they're holding themselves nice and straight and they are, strong posture, or they are saggy and barely standing on their feet. Okay? So joint, tendon, and muscle receptors. Okay, so so what those muscle receptors do? So they detect changes in tension and position of structures, provide feedback to the nervous system. You got either joint compression or joint distraction, and we talked about this already. So we need some features which are going to tell your brain which are we compressing too much. Perhaps we might injure ourselves by compressing those muscles too much, or we can distract the muscles, elongate the muscles perhaps too much. How do we know this? Well, we have Golgi tendon organs and muscle spindles which are responsible to give this information to the brain, and this is a part of our reflexes. So we don't think about it, we don't have to, it just happens. Okay, so let's talk about Golgi tendon organs first, and remember those are Golgi tendon organs, not Golgi apparatus, which you have in the cells. Okay, so Golgi tendon organs are located in tendon area, and you can appreciate just by looking at the name, tendon organs. So if you see on the test, for example, Golgi tendon, and the question is going to be where it's located, in the tendon area. All right. What else? So Golgi tendon kicks in when it's over flexion of any given muscles. So when you are holding something very, very heavy and you are pressing and pressing and pressing and pressing, at one point the muscle is overloaded and you can physically damage that muscle. So the reflex kicks in. You don't have to think about it. It just happens. How the reflex works? What does it biologically happen within your muscles? Well, the Golgi tendon organs inhibits the contraction of the agonist, but at the same time facilitates the contraction of the antagonist. So apparently you have to know what is agonist, what is antagonist for any given movement. So this is easy to explain and show with this camera. I get used to that camera a little bit already. So as I'm compressing more and more and more, and let's say I have something very heavy in my hands, my juice is probably not enough, but if I have something super heavy and I needed to bring it up, what the Golgi tendon is going to, how the Golgi tendon is going to react when the muscle is feeling like, okay, it's enough of that contraction, I can't do anymore. It's going to inhibit the contraction of my biceps. It's going to stop the contraction of my biceps. But at the same time, it's going to promote or facilitate my the contraction of the antagonist. The antagonist of the biceps is, of course, triceps. So instantly the biceps relaxes and the triceps kicks in. And if you try that at home, be very careful, don't damage your joints or your muscles. But I tried, I really did. I took a very heavy dumbbell, way too heavy for me, for my normal exercise regime, but I was forcing my muscle to work as hard as the muscle could work. And when I was right here, I saw it with my naked eye. My biceps slacked, it relaxed, and literally was like this. I'm lifting, and that was it. This Golgi tendon worked beautifully. Spindle, of course, is the opposite. Okay, so we said that Golgi tendon organ sits in the tendons. So where you can find the spindle, the opposite. What is the opposite? The belly of the muscle, right? So spindles are in the belly of the muscle, and they are going to do the opposite what Golgi tendon organ did. Therefore, it promotes contraction of the agonist and releases or relaxes antagonist. All right, so the situation now is the opposite. I'm going to stretch